Hello and welcome to the Oncology Journal Club podcast, where oncology papers meet real-world practice. I'm your producer, Rachel Babin, and joining me again are Professor Craig Underhill, Dr. Kate Clarke, and Professor Christopher Jackson. Together, they dive into the research shaping cancer care, the important, the intriguing, and the sometimes controversial. This podcast is proudly produced by the Oncology Network. Head over to oncologynetwork.com.au for the show notes with links to all of the papers discussed today. Okay, over to you, Craig.
G'day. Welcome to episode 2 of the Oncology Journal Club podcast, ASCO special, or post-ASCO special. G'day, Professor Jackson.
Kia ora. How are you, Craig? Did you miss out on being at ASCO this year? Were you sad not to get your Qantas PJs?
I was, yes, very much so. And Kate, how are you doing?
Chris is winning on bingo already. Very well, thank you. Very well indeed. Finally getting over. It's ridiculous. You're only there for a week. Completely throws your sleep up the yin yang. But back again. Yeah,
it does. So we're going to be playing ASCO Oncology Bingo. Or Rachel's going to be playing bingo. Get out your bingo card, Rachel. And there's some bonus points. Every time Christopher mentions that he presented at ASCO, there's a bonus point. Anytime that I mention Qantas pyjamas or missing out or mispronounce a drug name, you can get a bonus point. And for Kate, it's anytime she mentions sexual dysfunction, menopause, or vaginas, we get a bonus point.
So what's the thing going to be scored out of? It's going to be scored out of like 100 because Kate's going to mention those things like 30 times each.
Yeah.
All right.
So this will be a bit of a cook's tour through the conference centre with some quick bites, various tumours and new things. Some of them practice changing, some practice affirming, or some just interesting new data. Just to recap with episode 1 for those who haven't listened yet, and we've had sort of a pretty impressive uptake or downloads in the first 36 hours since that was released. We're very pleased and thankful for all people who have done that and listened. We basically went through the plenary session. There was some fantastic papers presented. Proteus paper, which is using perioperative apalutamide in men having radical prostatectomy, abemaciclib in patients with advanced dedifferentiated liposarcoma. The Kate talked about adjuvant stelpuscatinib in stage 1B, 3A, RET fusion positive non-small cell lung cancer, the libretto trial. Harmony 6, adding ivonescimab to chemotherapy and tislelizumab in squamous cell carcinoma. And the one that got all of the attention, Resolute 302, daraxonrasib for metastatic pancreatic adenocarcinoma. So it was a pretty impressive plenary session. But let's get into episode 2. Professor Jackson, you're going to tell us about some GI, no doubt, and some melanoma papers as well.
Yeah, thanks, Craig. I'll start by covering off the colorectal session. I think the colorectal stuff this year, not heaps of stuff was practice changing, but it's good just to go over what we had. We'll start off with the colorectal LBA 3500, which was circulating tumour DNA in stage 2 colorectal cancer, which used an academic tumour-informed circulating tumour DNA assay, so it was cheaper than the standard commercial ones. And they randomised people who were ctDNA positive to capox or capecitabine or observation. If they were ctDNA, they were randomised to observation or off study. So it was attempting to move from simply being prognostic to being predictive. The very sobering finding on this was only 4% of patients were ctDNA positive. So it was actually pretty hard to use the circulating tumour DNA positivity as a strategy for stratifying who should get chemo and who shouldn't. In stage 2 colorectal cancer, the conclusions of the study were that ctDNA remains strongly predictive, but not enough data regarding its predictive power. And it may just be because our tools in adjuvant are blunt. Capecitabine, capox is a pretty blunt tool, no real escalation or intensification strategies there. And I also wanted to do a quick shout out to Margaret Lee and Jenny T from Melbourne, who had a poster in the colorectal session on peritoneal tumour DNA as a predictor for peritoneal recurrence. So good on them for bridging the EU divide there. And Margaret was presenting a poster there, had a lot of interest. LBA 3502 was I love this one, a Chinese abstract. Why do people even have to say what country it comes from if it comes from East Asia, right? Why do they do that? Anyway, this was a really great observational cohort study of deficient mismatch repair colorectal cancer, patients who were treated with immune therapy. In this situation, people were either treated for 2 years or to CR plus 2 cycles. So it's a duration study, an observational duration study. And what they found was that numerically, those who were treated to CR plus a couple of cycles, only 1 or 2 of those patients actually relapsed and they were both salvageable. And there was no clear survival gain for those who continued for up to 2 years of maintenance IO. And the grade 3 tox was lower with the CR plus 2 strategy compared to the 2 years maintenance, with grade 3 tox rates of 3% versus 11%, which of course is subject to ascertainment bias, so observational study, hypothesis generating, etc., etc. But, you know, it's pretty daft that we use this very arbitrary 2-year duration of IO, isn't it, for most of these studies, and having some kind of duration which is rational, at least seems like a great way to go. And this might encourage people to do a genuine randomized duration study. Would love to see that happening. Well done to the investigators for reporting that abstract and getting that into the oral session. 3503 was the Breakwater Folfuri study. So just to recap, Breakwater is for BRAF mutant metastatic colorectal cancer and was a randomized study between dealer's choice chemotherapy and FOLFOX with Incosatux or Folfuri with Incosatux. Now, they had a safety lead-in for Folfuri because there's a theoretical interaction between irinotecan and encorafenib, as they thought that might cause problems. So the safety lead-in found there wasn't a major safety signal and then went on. Now, we've all had the FOLFOX Incosatux versus chemo arm. We know that's been reported before. And we know that's positive for PFS and OS, so doubling of both PFS and OS compared to dealer's choice chemo. And this was comparing Folfuri EC to chemotherapy. Now, the highlights of this were that we saw a median PFS of 15.2 months with Folfuri EC with no new safety signals. Thank you. No new safety signals. And actually, if you compare that to the FOLFOX arm in the study, it was actually only a median PFS of 12.8 months. Of course, with FOLFOX, Incosatux, you drop the oxaliplatin and they start to give it a bit of neurotox, but with Folfuri, you're not dropping the doublet. So you continue on for a bit longer. So maybe that doublet with Folfuri might even turn out to be a better strategy in the longer run. This is not a clean comparison of FOLFOX or Folfuri backbone with Incosatux. That's not what the study was reporting at this stage, but it is showing that Folfuri with Incosatux is a perfectly acceptable choice in that BRAF mutant population. I think that's practice affirming. Many people are already using Folfuri Incosatux or equivalent, and that's because many of our patients have already relapsed adjuvantly and so are not able to have oxaliplatin for other reasons. So I think this is reassuring. LBA 3504 was a second-line BRAF mutant population. It was looking at Incosatux plus minus Nivo, because a previous single-arm phase 2 study looked at whether or not Nivo Incosatux might have some activity in people who've previously been treated with BRAF mutant MSS, microsatellite stable, not DMMR, microsatellite stable colorectal cancer. And the long and the short of it was that it was a very negative study, so please don't go giving your BRAF mutant patients who've relapsed Incosatux with Nivo. Don't do that outside of a clinical trial. Very important not to follow that strategy at this particular point in time on the basis of the evidence we've got. 3505 was a HER2 positive population, looking at an antibody-drug conjugate of trastuzumab risatecan, so not deruxtecan, but risatecan, which is allegedly better because a different company makes it. And that was compared with standard of care chemotherapy. A little bit of a growth in PFS, plus 2.5 months. Hazard ratio was pretty good at 0.33. I'd call that a signal rather than a slam dunk. PFS gain of plus 2.5 months is only really an ESMO 2 or 3. MCBS score's not very high, but it's a signal that targeting HER2 with drug antibody conjugates may still be a good strategy. And the last decent one out of the colorectal oral session was the cost effectiveness study from the Challenge exercise study. People remember that Challenge is the most important study never to get an ASCO plenary of adjuvant exercise in fully resected stage 2 and 3 colon cancer following on from adjuvant chemotherapy of structured exercise versus usual care. This was the cost effectiveness study. And what I love about the study is it showed it actually saved money. compared to usual care. And that was because, of course, it stopped people relapsing, and therefore funding the structured exercise program actually saves their health system money. One of the key points they mentioned, though, was that you have to really pay the exercise people per hour, because if you pay them on salary, it might not deliver those savings. So it's important still how you structure the funding for it. That's been published in JCO and is available to look at. So post it to your local HTA or your local hospital administrator and say, look, I found a way to save money. Next time you're told to save money, go, I've got a way, set up an exercise program. It'll save you money, and see if they jump at it. They were the key highlights from the colorectal session.
I just wanted to stress that the cost effectiveness, when you save money, it's called a dominant strategy. And I just think that's brilliant on the health economy nerds to come up with that concept. So it's a dominant strategy, which means that we should all be doing it.
Dominator.
And CJ, how did they save money? Was it both saving readmissions or relapses? And
yeah, saving relapses, Craig. So, I mean, if you're saving relapses and you're saving the interventions that you need to do when those people relapse. And so it was a really good cost effectiveness study. Very detailed. They did all these things called bootstrapping and stuff, which I don't really understand. But I do so like a study that confirms my biases.
yeah, fantastic.
And that was one of them.
When the challenge study was released, I think it was last year, I remember there was a mention that there was more papers to come, including on cost effectiveness. So that's great to know that it was positive. Fantastic. Because that's often touted as a barrier, just an additional cost of having to set up exercise programs.
Yeah, and one of the things that I mentioned in my ASCO session that I talked at, was that most of our health systems don't actually have very good pathways to reimbursement for these non-drug-based interventions. And you'd have to think that if adjuvant exercise was a drug, so we call it exercisamab, that it will be funded by most health systems at the moment, because you've got very rapid pathways for evaluation and reimbursement. And most of our systems, like the PBAC or Pharmac in New Zealand, we just don't have those systems for funding health systems interventions. But a clearly cost-effective intervention that reduces overall deaths by as much as oxaliplatin and more than Herceptin and HER2-positive breast cancer should be a slam dunk for most health systems. But it's really still not funded routinely in most health systems anywhere.
But it is truly a whole of health system benefit. And the tricky part is which part of the health system is going to front up with the cash first. And I suspect there will be arguing for ages about that, even though we acknowledge the benefit.
I'm sorry I missed your presentation at ASCO, Christopher, but I did enjoy watching some of the sessions online in my Qantas pyjamas. Would you like to go next?
Next.
Hopefully only cover a bit of breast cancer. There was some pretty exciting abstracts in breast cancer, I thought.
Yeah, look, I think the most exciting, though I suspect many drug companies won't agree with me, the most exciting is Optima, which did recruit in both New Zealand and Australia. It was through I can never get the acronym right, ABCDCG, lots of letters. Rob Stein's group, I worked with Rob in 2008, so this is something that has taken a long time to get here out of UCLA. And the concept was looking at a much higher risk group of women in the adjuvant setting. So they did include men, but it was by and large. So people with breast cancer in the adjuvant setting, much higher risk. Your oncologist working in mostly Britain and Australasia had to be comfortable with you needing chemotherapy. And then they were split into a control arm and a test-directed arm. Those people who were in the control arm were mandated to have chemo, mostly docetaxel cyclophosphamide, followed by endocrine therapy. Premenopausal women had to have ovarian function suppression as standard. Then in the test-directed arm, they had Prosigna, which is the more affordable of the commonly used gene assays. And then to be called high score, you had to have a score of more than 60. That only applied to a third of the women who were in the group. And I'll come back to the group inclusion in a second. And then if you had a low score, you just got endocrine therapy, including ovarian function suppression if you were premenopausal. Otherwise, you were if you're high score, you've got chemo endocrine. Trial had some really nifty, relatively modern things included in it, in that the non-inferiority margin was decided by a community, including patient advocates, which I think is really, really important. So they were comfortable with a 3% absolute non-inferiority margin for invasive breast cancer-free survival. And the inclusion, the women, only 10% were node negative. It included women over 40. So that's quite young women. Significant number, 20% had 4 to 9 lymph nodes involved. So this is what we would consider a high-risk population. As it's close to 70% of people had a low-risk score. Associate Professor Stein was quite clear that they tried in their start, they used Oncotype DX as well, but Oncotype DX gave significantly more women high-risk scores. The non-inferiority margin was not breached. There is a numerical difference in the groups between either test assigned or giving everybody chemoendocrine of about 1% on all endpoints, so invasive breast cancer-free survival, distant recurrence-free survival, confidence intervals clearly crossing 1 and all of those things. And that included, they've broken them up by menopausal status, they've broken them up by age, they've broken them up by traditional stage. So I think this is a great strategy. So health systems can avoid spending thousands on chemotherapy and the admissions thereof, and women can avoid 12 weeks of what is significant downside to their lives. So this is very awesome. So I was very excited by that. Lovely to see Rob looking so well. Yeah, it was good.
Can I ask a question on that one, Kate?
Of course you can.
The Optima test was, so how many of those women considered high risk were found to be low risk on the Optima test?
So 70% of the women who had clinically high risk disease.
7-0, it's close.
7-0. It is quite high.
And did you say they all had the Oncotype DX as well? And there was discrepancy between the two?
No, not all of them. In their pilot phase, all women had both, and there was significant discordance, and Oncotype DX put more women into a high risk group.
Yeah.
The published data is about the Prosigna, and even with the Prosigna putting more women in the low risk group, the difference is still insignificant between a chemoendocrine strategy and a risk adaptive strategy.
Great. And this was survival data, or this is relapse-free survival?
We're only at 5 years. So we've got invasive breast cancer-free survival and distant recurrence-free interval. The feeling is, and it has been what's called Ponderex and TaylorX all did 5 year as well, because that's apparent. That is the feeling. That's the chemo-prevented recurrences. The late recurrences are hormone-related recurrences.
Okay.
It's pretty exciting. So I know everybody's furiously writing to their funders to say if you don't have access to these, you probably should.
And just for people who don't know, the Oncotype DX is kind of the standard, which is thousands of dollars for the test, and this is hundreds of dollars. Is that correct?
No, sadly, this is still thousands of dollars. Okay. It's fewer thousands of dollars, but it's still thousands of dollars.
Okay.
But cost saving. Then I wanted to very briefly talk about a trial that I think was mostly done looking for the safety, but has come out with an interesting hypothesis. So American College of Radiology took a crazy number of women who'd had any kind of breast imaging over several years and looked at their GLP-1 use and looked at their incidence of breast cancer. Understanding this is a retrospective observational study, they've done that propensity match business, which I would never understand. But there is a 30% reduction in breast cancer incidence. So GLP-1 agonists are probably safe in terms of breast cancer risk. Are they protective? That's for future study, but I'm fascinated by that. There were several GLP-1 agonist studies in other disease types too, looking at lower metastasis rate and all sorts of other interesting stuff.
I think that's a really important study, because I think that people think that GLP-1, when they reduce the obesity rates, will actually naturally it will follow that you'll reduce the cancer rates. But there's been some conflicting data in pancreas, for example, whereby some studies have shown a slight excess risk of pancreas cancer in GLP-1 users, whereas others have not found that. So I think it is important to continue to collect the data and to continue to look at that and keep an open mind about which way the relationship's going to go.
But being an endocrine-driven cancer, you would think that kind of biologically plausible in breast cancer, right?
Possibly, but also I think the other issue is that it's not a straightforward relationship. Sure, it's obesity, but also there's a degree of sarcopenia that the GLP-1s can cause as well. So you can lose muscle as well as fat. And so I think there's a complex interplay there between the body composition stuff. So I don't necessarily think it's a slam dunk that it's going to happen. Of course, it seems plausible and likely, but I don't think you should just assume it. And that's why the data should be collected. I don't think it's enough of a concern to say you shouldn't market it until you've got the data over 10 years or 20 years or whatever. But I do think it's important to continue to monitor and keep an open mind about what the possible direction of the risk is.
Yep. So the other breast cancer one I wanted to talk about really quickly was denosumab dose density that came out of the Swiss Cancer Institute. So many of us who treat breast cancer, we use bisphosphonates or denosumab, a slightly different mechanism, to prevent skeletal-related events, particularly in estrogen-sensitive breast cancer, where women may have very many bone metastases. And the standard dose for a long time has been Q4 weekly for a long time. Some years ago, a group of investigators, who I've forgotten about, suggested that you could, after a year, drop the dose of zoledronic acid to every 3 months, and that didn't seem to take away the benefit. Similarly, denosumab, you give a run-in of 4 weekly for the first 16 weeks, and then thereafter 3 months, compared with continuing on Q4 weekly, you have no loss in the control of skeletal endpoints, no difference in overall survival, but more importantly, fewer hypocalcemic episodes, fewer ONJ or tooth infections, so ONJ being osteonecrosis of the jaw, and significant cost and time savings. So another very sensible trial coming out. I think clinicians thinking sensibly about what we can stop doing to make room for the things that we should be doing. So that's quite useful.
It's always good to see some dose de-escalation trials. Do you have anything else to tell us, Kate?
I have one, maybe two, like interesting things. So we all got very, very excited, completely appropriately, about Daxon. Daraxonrasib. I always get it wrong. It's got too many syllables in it. Anyway, the brand name will be something like PDAC off or something, and we'll all be like, yay! Anyway,
Probably, cure them all.
But there's other really cool, new, sexy ways of targeting the KRAS pathway that are coming. And cyclic MEK inhibitors are one of the ones that I think is really exciting. So the drug here, and I've written it down so I can sell it, is atabim. I've got the giggles. You can try.
Bimentinib.
There we go. Thank you. Atabimentinib. And it's awesome in that the way that I think about it is it works on the MEK for only 2 or 3 hours. It's got a very short half-life. So that turns off your downstream signaling, but doesn't allow for resistance to develop as fast, but also allows your normal cells to keep doing their normal things, which I think is quite awesome. Convenient side effect of weight gain, which also in a pancreatic cancer population is awesome. So they gave this drug alongside a modified nab-paclitaxel gemcitabine, so every 2 weeks rather than 3 weeks on, 1 week off. And the difference, the progression-free survival in first line was 8.3 months, and the overall survival was 17.3 months. Which compares favorably with historic controls. So I'm very excited. There is a global randomized phase 3 on the way called MapKeeper. So they obviously understand that their name is too hard to pronounce. So I'm very excited about that.
Fantastic.
Kate, were there any abstracts that resulted in symptom improvement or improved quality of life, or, I'm trying not to say it, any possible hormonal benefits in patients of any of the studies that you discussed?
No, I wasn't actually focused very much on sexual function at ASCO. It might have been the company I was keeping.
And I think I was sitting next to Kate in a couple of sessions while Craig was at home in his Qantas PJs, and Kate was complaining about the temperature in Hall D, which those who've been to ASCO in recent years will remember is a frequent problem. And Kate said, "Where's a hot flush when you need one?"
I well did, honestly. I could have popped out an eye with the nipples that I had on me.
You're going to really do wonders for our R ratings on this particular podcast. You know, why has the Oncology Journal Club got an R rating for a scientific review?
I did have one more. I found this really interesting. This is another unpronounceable drug, onvansertib, plus standard of care chemotherapy, plus bevacizumab, in first-line RAS-mutated metastatic colorectal cancer. Onvansertib is a highly selective oral small molecule inhibitor of PLK1. So it is involved in mitotic progression, DNA repair, and tumor cell adaptation to hypoxia. So if you block that, you make cells uniquely sensitive to irinotecan, but not uniquely sensitive to oxaliplatin. And so what they did was they looked at FOLFIRI, onvansertib, and bevacizumab versus FOLFIRI, bevacizumab, and FOLFOX, onvansertib, bevacizumab versus FOLFOX, bevacizumab. There's no difference in the oxaliplatin arm. It's exactly the same. In the irinotecan arm, there is a significant difference. And obviously, this is early. This is phase 2. Significantly more responses. Those waterfall plots look really sexy, including 1, 2, 3, 4, 5. So that's probably 30% CR rate, which is pretty, in metastatic colorectal cancer, you don't see that a lot. Progression-free survival not reached yet, but overall response rate 72% versus 40%. So I'm hanging out for some of this more synergy and thinking. So that's an onvansertib.
Yes, but was the toxicity manageable? If it caused hypoxia, what happens? Your toes fall off, or what? What was the toxicity?
Well, this is the problem with those 5-minute abstracts, is we won't know until that gets published properly.
Okay.
So this is the polo-like kinase 1 inhibitor, PLK1, rather than a HIF.
Yeah.
Because New Zealand did a bunch of HIF alpha studies for a while too, but unfortunately that didn't really go anywhere.
So I think the interesting thing here is that although it's not supposed to work on cell adaptation to hypoxia, the real benefit seems to be in its synergism with irinotecan. So the irinotecan goes in and blasts the DNA, as topoisomerase inhibitor, and then this comes in the way and goes, don't fix yourself, please. So it's so you end up with that lovely illogical term of synthetic lethality. It can't fix itself.
Which is just a sulfate link, right? You get the DNA cross-link or DNA adapter thing, the oxaloplatin, the 5-FU, which is supposed to stop the DNA repair. Same thing. It's working additional pathway there. Cool.
So this is all up inhibitors, Kate.
Yeah, biology that you need to know.
Yeah.
Sounds pretty clever, though, to work out that mechanism that it synergizes with the sulfuric. All right. So I've got a few to do. Back to lung cancer. So this was late-breaking abstract 8,500, the Wukong 28 trial. First-line sunvasertinib showing superior efficacy over chemo alone in advanced non-small cell lung cancer with EGFR exon 20 insertions. So there's been an absence of effective therapies for these type of lung cancers with the exon 20 insertion mutation, have fewer effective options compared to the more common exon 19 deletions or the L858R. And so this was touted as potentially a new standard by the discussion for this rare lung cancer. It's an oral treatment. So this was a single agent versus combo chemo. 90% of the patients crossed over. So Chris, the last episodes, thought that wasn't a great thing to do in the first study of the drug. So despite that crossover, the median progression-free survival was significantly longer, 10.3 versus 7 months, 59% versus 31% response rate. Median duration of response, 11.2 versus 7.1 months. Overall survival, immature. There was no quality of life data. And of note, there was a higher rate of diarrhea from this agent. But interesting data, and given the absence of effective therapy other than chemo, it would be interesting to see where that goes in the marketplace.
Craig, can I just jump in there and say thank you for raising the crossover issue. There's a very good review on the ethics of crossover, which is actually written by Vinay Prasad, but there's a 2014 review or article on the ethics of crossover trials, either mandatory or where crossover should be withheld. It's worth a read, actually.
Thanks, Chris, for highlighting that. So we'll put that in the episode notes, and we'll put it on our new resource tab on the website, Rachel, so people can find that in the future as well. So another molecule touted as a possible new standard in lung cancer. This is an interesting study. This is Optitrope Lung 05. So this is ADC, the sacituzumab tirumotecan, given with pembrolizumab in PD-L1 positive advanced non-small cell lung cancer. So in the past, we've had just single agent pembro as an option. This is adding the ADC to it. First phase 3 study doing that, or first phase 3 study reported. Median progression-free survival not reached versus 5.7 months with a hazard ratio of 0.35, so substantial reduction in the risk of relapse. And the 1-year progression-free survival, 62% versus 29%. There were no new safety signals, but the extra toxicity of adding the sacituzumab tirumotecan to pembro, you get all the usual side effects of the IO, but there's an additional grade 3 neutropenia, anemia, stomatitis. Now switching track to GU. We had some follow-up data, abstract 4507, which is enfortumab vedotin plus pembro versus chemo. So we've talked about that in the past. I think it was presented at ESMO last year or the year before, or maybe ASCO last year, showing survival advantage with this non-chemotherapy containing regimen for patients with locally advanced or metastatic urothelial cancers. So this is a 3.5-year follow-up. So patients in this study had to be PD-1 naive, ECOG 2 or less. So they did throw in the ECOG 2s. Often these studies have 0 or 1 patients. The chemo was 6 cycles of standard gemcitabine and a platinum. The enfortumab vedotin was given until progression, so quite a lot of drugs. So that's relevant because I'll get to the toxicity in a sec. So the 3.5-year follow-up data showed overall survival 33.6 months versus 15.9 months, a hazard ratio of 0.5. So basically doubling the benefit. You get the usual side effects of the pembros with all the itises. But interestingly, in the patients receiving the enfortumab vedotin, they have a cumulative peripheral neuropathy. Grade 3 is uncommon, but close to a 90% rate of sensory neuropathy at 2 years. Overall, the grade 3 toxicity is less in the EV arm compared to pembro. And, this is a study in people with locally advanced disease or metastatic disease. So at 3.5 years, we still haven't seen quality of life data presented in this group, which will, I think, help in the decision-making process. And following on from that, because so far the enfortumab vedotin is only available in US and Italy, so other countries have not listed this, including the rest of the EU, despite the Italian listing. So this was a study that's relevant probably in other jurisdictions, and also an option where people have relapsed after the enfortumab. This was a study called DISCUS, giving avelumab maintenance post-chemo for locally advanced or metastatic urothelial cancer. So this was a de-escalation study, 3 cycles versus 6 cycles of chemo, and there was an identical overall survival. So it looks like 3 cycles of chemo is enough, and then you give the 12 months of the single agent PD-1 inhibitor. And they reported quality of life as a major endpoint. And Chris has just fallen off his chair. And
big ups to those investigators for doing that. That's awesome.
Yeah. And so interestingly, the biggest deterioration in quality of life was with the 6 cycles of cisplatin. You could probably predict that. Less so in the patients getting carboplatin. The highest grade 3 treatment-related adverse event was in the 6 cycles of the carbo arm, mostly related to haematological toxicity, which makes sense. But so there was a trend in favour of better overall survival with cisplatin, but not statistically significant. So really identical overall survival of about 18 months, regardless of whether patients got 3 or 6 cycles of chemo and whether it was cisplatin or carboplatin based. So this is a really pragmatic trial, I think, for most of the world that doesn't have access to the new agents.
I mean, that's great for a number of reasons, Craig. A duration study with de-escalation as a strategy. That's cost saving as well as time toxicity saving. And quality of life is a major endpoint. I think there's a lot to like about that.
Yeah. Last one in neurological cancers, abstract 5505, phase 2 ARACOG trial, enzalutamide versus darolutamide. So we've known for a long time enzalutamide crosses the blood-brain barrier, and there's been concerns about cognitive impairment. So this was a investigator-initiated study comparing enzalutamide versus darolutamide, and the enzalutamide patients did in fact have lower cognitive scores. So it's proven the point there is a difference clinically between these 2 drugs. So I suspect that enzalutamide usage will be on the decline in the jurisdictions that have access to darolutamide as well. Changing gear, and we're going to mangle this drug for sure. Abstract 5515. This was a study in ovarian cancer and endometrial cancer, the Blue Star study. This is a B7H4 directed topo-1 inhibitor called puxitatuk samarachikan. That gets the prize for the hardest ever same molecule, I think. So this was a phase 1-2 study, active new agent, response rates of 47% in ovarian cancer and 24% in endometrial cancer. I want to mention too, we don't often cover a lot of haematology, but this may be the first study in decades to beat the current standard for patients with high risk diffuse large B-cell lymphoma or high-grade B-cell lymphomas of adding a new drug called tafasitamab plus lenalidomide to R-CHOP. So for many, many years, R-CHOP's been the standard. This tafasitamab is an anti-CD19 monoclonal antibody, which is found on the surface of B cells. So the overall survival data is immature, but at 32 months, there was a 25% reduction in the risk of progression or death versus R-CHOP. The final analysis for overall survival will be at the 5-year mark, so 2.5 years in. There is a slightly higher grade 3 toxicity, 86 versus 76%, which we, in hematology studies, that's not unusual. But the ability to deliver the standard R-CHOP wasn't compromised by adding in the extra monoclonal antibody. So again, the discussant thought this was a new standard. It was concurrently published in the Lancet. So the benefit was across subtypes of different types of high-grade lymphoma. So
can it be a new standard for medical oncology if it's not published in the New England Journal of Medicine, Craig?
I don't know. They'll have to ask a hematologist whether the Lancet was okay or not.
I think what's interesting about it, it's been many years since I've treated lymphoma. I did my fellowship in lymphoma, but it's been a long time since I've treated it, so I'm certainly out of days. But CD19 obviously has always been a marker for DLBCL and B-cell malignancies. So I'm surprised it's not come up as a target more recently, Craig. Is this an area you know a lot about? Has it been a relatively recent target that we've been exploring, or is it one that's been hard to drug, or what's it about?
I don't know. I used to co-manage patients with lymphomas when I first moved to Albury, Chris. So we'd present them at MDT in the city, and then we'd carry out the components of care that we could deliver. So we're used to giving R-CHOP, but I don't know. The answer to your question is how long has this been in the offing, this molecule? So anyway, it's, potentially a long time since R-CHOP.
Yeah.
It's close to 20 years since R-CHOP's been beaten in a phase 3 study.
Well, that's right. Long live the king, right?
Yeah.
This might have long-term. So CD19 is the common CAR T target for B-cell lymphoma. So that's interesting. I think also I'd be curious to know long-term how these people do with if you completely wipe out your B cells, what kind of lifelong other problems people have.
That's right. That's a weird thing about lymphoma treatment in general, Kate, is why they don't do worse longer term, eh?
I don't know if they don't. I'm just not sure that we've been following them long enough. Because I think, and this is just a theory, but I just think we're making these people's immune system old before their time. And so are we seeing more cancers in survivors? Well, that will take a while. If they're 25 when they get their lymphoma, they might not be 50 when they get the cancer, but they may not have got it otherwise. So I'm just curious.
Time will tell. It's very early days, but there may be a new standard challenging R-CHOP. And then it's going to finish with 3 negative studies. I think it's important that we do mention those. So late-breaking abstract 8,000, the ECOG Akron EA5142 study, adjuvant nivolumab post-adjuvant chemotherapy and resection of lung cancer, a negative study. Again, reiterating, we keep seeing this time and time again, the perioperative approach seems to be more effective than just giving adjuvant checkpoint inhibitors. And the Rampart adjuvant study, which was a comparison of durvalumab versus surveillance and durvalumab plus tremelimumab in patients with high and intermediate risk RCCs being resected, and that showed that the durvalumab on its own didn't work. Durva and Tremi had a longer disease-free survival compared to surveillance, but we already know from Keynote 564 that 12 months of Pembro had an overall survival advantage in this population. So looks like the durvalumab's not as effective, certainly not on its own. And once you start adding in the CTLA-4 inhibitor, of course, the risk of life-changing itises goes up. And then lastly, interesting study, abstract 5019, the Pluto study from the Canadian Clinical Trials Group. This was a study designed with de novo crossover, Chris. This is men with castrate-resistant prostate cancer, the old term that we no longer use. But this was randomizing men to receive lutetium up front, followed by docetaxel, or the other way around, getting docetaxel up front, followed by the lutetium, and there was no difference. And so in people who can access lutetium, which is not in every jurisdiction or in every region within Australia, and regional patients have more difficulty accessing lutetium, there's no difference in the sequence of providing those treatments. So I just thought I'd throw that in as a pragmatic real-world study, like the one where we de-escalated from 6 cycles to 3, adjuvant checkpoint inhibitor.
And did you read all of those abstracts and watch all of those sessions in your Qantas PJs, Craig, just for nostalgia?
I did watch them in my Qantas pajamas.
I'm glad, because that's state-dependent learning, right? So you're probably going to go to clinic now in your Qantas PJs. You've taken the information in your Qantas PJs, therefore you need to only be aware of it when you're in your Qantas PJs.
And so when I get home in winter, it's nothing better than popping your Qantas pajamas on. It's dark outside. And Mr. Qantas, if you're listening, we are open to sponsorship as well.
Free flights. And also with all these pronunciation issues, Craig, as well. I mean, I think we're just yearning for the days when the only randomized controlled trials at ASCO were Folfox, Folfiri, Avestin, and cetuximab, right?
I know.
The good old days.
Good old days.
Cases or studies on panitumumab.
Exactement.
Just got a couple of quickies just to finish us off with. Upper GI, HCC, LBA 4000, Emerald 3, due to come out in Lancet Oncology shortly. This is inhibitor cellular carcinoma, looking at TACE versus TACE plus Stride. I'll say what Stride is in a second. Versus TACE plus Stride plus lenvatinib. Now, Stride is single tremelimumab, regular interval durvalumab. So 1 dose of tremi and then durvalumab. So now durvalumab and tremelimumab is a standard in advanced unresectable post TACE HCC. So this is bringing it slightly earlier in the setting. And this looked at those 3 arms and had hierarchical testing for comparing the arms. So it's quite hard in a 3-arm study to work out how you test and in what order. And if as soon as you're doing hierarchical testing, as soon as you find one particular comparison is negative, you don't go on and do the full comparisons of the following comparisons, which makes it a little bit difficult when anyone wants to compare various arms themselves, but statistically you're not supposed to do that. The bottom line was that with Stride, Lenva versus TACE, the PFS was better with the multi-drug approach, and 2-year PFS went up by 10%, which is actually quite a good gain at 10% increase in 2-year PFS. Overall survival was negative, though, with a hazard ratio of 0.84, so not nearly as good as those studies Craig was citing, where they had hazard ratios of 0.5 and 0.6, but median overall survival only plus 4 months. So the Stride versus TACE only, OS was not mature, hazard ratio was a bit better at 0.7. But looking at between the curves, it looks like Stride versus TACE might give you some PFS gain. I need a little bit longer to see whether that translates into a meaningful OS gain, which is statistically significant. And there doesn't look like there's a major benefit of adding Lenva, which is good because it's not a very nice drug, actually. So save Lenva for later in the piece. In melanoma, I just wanted to mention abstract 9500, which is the long-term follow-up on Indesmirin autogene, which is an mRNA individualized neoantigen therapy where the individual patient tumor is sequenced and up to 34 patient-specific neoantigens are identified. They're mixed up with the mRNA and they're administered to patients, and this was Indesmirin autogene. So kind of like Sipuleucel T, which was an individualized therapy, same idea, individualized therapy, mRNA vaccine with Pembro in stage 3B or 4 resected cutaneous disease. RFS gain is quite impressive, plus 22% at 4 years. So that's above Pembro alone in resected patients, quite a good EFS there. But OS, encouraging trend, but remains immature with a hazard ratio of 0.471. So a trend towards significant DQ, trend towards events there, and immune-related adverse events appeared similar. And the final one I want to give a quick shout out to, which is really worth reading in this month's Lancet as well, is the Lancet Commission on the Workforce Crisis in Cancer, which was presented in the adjacent theatrette to my session at ASCO. But the Lancet Commission on the Crisis in Cancer Workforce is predicting a workforce shortage of 100 million workers by 2050, which is a very large number. 100 million is very large, but 9 out of 10 of those were non-oncologists. So they are things like primary care physicians, radiologists, pathologists, and of course nurses as well. So I think it's important for oncologists, as we find our clinics are getting fuller and fuller, where many of us have waiting lists these days as well, and as we're feeling overwhelmed, we need to reflect on the fact that actually there are many other parts of the oncologic workforce as well, which also are under a lot of strain, and we need to tend to all parts of the garden, not just our own bushes, correct, Kate? Otherwise, we will mean that we have an unbalanced garden in years to come. So, yeah, I think that's an important piece of work, well worth a read. There are a couple of cool commentaries to go along with that, including a commentary that myself and Tava wrote for Lancet Oncology as well, about the Pacific on that as well. So a great presentation at ASCO by that team, and an excellent accompanying commentary and a fantastic commission well worth reading.
Fantastic, Chris. 100 million shorted. How many people live in New Zealand?
Well, there's a lot of sheep, but there's 5.2 million humans.
Yeah, so God forbid, multiply New Zealand by 20 times.
Yeah.
Could the planet cope with that? And that's the shortage of healthcare workers in Canada.
Lots, eh?
Amazing.
We know you're amazing, Craig, and you could probably be qualified for like about 10 million of those workers.
Yeah, no.
But we still need 90 million more.
Yeah, incredible. Okay. Wow. So that's been a bit of a cook's tour. Lots of practice changes, potential practice changes or potential new standards this year. I think the real theme was around that ongoing drive towards precision medicine driven by new treatments, driven by new targets, individualized care in patients. So very interesting ASCO overall, I would say. What do you guys think?
Yeah, no, it was really good. It was good to be there. It had a different feel this year, Kate, didn't you think? Slightly, it was more of a hypothesis generating some early phase stuff on ADCs and BiTE therapies, really. Lots of emerging stuff from China in particular, I thought, which was quite a different flavour to other years. It seemed like a far fewer attendees from our part of the world. Yeah.
Yeah, it felt to me more sensible. Like we're not just, feels like people are making logical decisions rather than just throwing recipes at cancer and hoping it works, which is nice. So went to a talk 20 years ago, Rakesh Jain goes, you can't just keep throwing all the drugs we have in different combinations and praying it'll work. He's finally being listened to.
Fantastic. Thanks very much. Thank you, CJ. Thank you, Kate. Thank you, Rachel. Did you win the bingo?
Oh, I definitely did.
Fantastic. So, as always, invite feedback. You can do something clever on a WhatsApp link to send us a sound file or a typed comment. And we will talk to you all soon. Goodbye.
Kia ora mate wa.
Bye-bye. I'm off to have a non-alcoholic beer with my boyfriend.
Good luck.
Who is my husband.
Yes, he's listening.
Who is also my husband.
That's it for this episode of the Oncology Journal Club podcast, where oncology papers meet real-world practice. If you'd like to explore the papers we discussed today, head to oncologynetwork.com.au and visit the Oncology Journal Club tab, where you'll find show notes, links to the research, and a growing collection of OJC resources. Don't forget to join the Oncology Network. It's free. You can send us voice notes and chat with us on social media. And physicians, you can also claim CME points for listening to this show. This podcast was proudly produced by the Oncology Network. Until next time, thanks for listening.